So welcome to recall session for CET. So what's the purpose of releasing a recall like this after the exam is done? It's just for the others who preparing, who are gearing up for the upcoming exam. It's for them to get an idea of what the exam is. And idea is really a word that's very important here. Because INI, unlike NEET, is a very new exam because we had AIMS, DIPMER and PGI separate exams for a long time and then only we had these INI exams. INI exams have been now going on. We've had almost 6-7 INI exams till now. And what we have understood about INI exams is INI exam is just about getting the set piece right and scoring out of it. That's it. It's not like studying the whole thing. Studying the whole thing is not required because it's the same area which keeps on getting repeated. It's not like they find out new areas. That's why you can see Harmanpreet Singh here. Who is Harmanpreet Singh? Harmanpreet Singh is a penalty corner specialist like Sohail Abbas of Pakistan, who is the world's best penalty corner specialist. Harmanpreet Singh, Sandeep Singh, they are India specialists, and Harmanpreet was pivotal in India lifting the bronze at Tokyo in 2020. It's like after a long gap that we had India coming out with the medal. And as with cricket, I'm really fascinated about hockey also. And this is what your field goal versus penalty corner is basically what is INI CET versus NEET. A field goal has to organically happen. Okay, that means you can't prepare to score a field goal. But penalty corner is something that if you prepare properly, if you have the technique and you prepare properly, you can convert. So this exam is actually speaking a case of penalty corner conversion, in the sense that you have set pieces and you have to score of those set pieces. You know these are the set pieces. These are the questions that will come. We have to just convert it into goals. You don't have to study anything more than that. We don't have to study anything less than that. Overall knowledge is not required. Overall having grip on each of the things is not required. It is our general understanding that will take us through in a NEET exam. It is not anything else. That means general ideas. But in INA, there are no general ideas. Specific ideas about specific topics. We keep studying those topics again and again and again. I did INA recall May 2020. I did INA recall November 2020. It is the same topics that we are doing again. I did INA recall in 2021 and this is the same. It is the same. The topics just don't keep changing. It is the same topic and a new question. A same topic and a new question. That means once you know to convert your penalty corners, you don't have to know even to play field hockey now. Even if you don't know to play field hockey, if you are able to generate penalty corners and convert penalty corners, you are always going to be thumbs up. Okay, so let us start off with the first chapter, and that is endocrine. Endocrine was newer bottles with the old wines. No, it's like all the same topics. What should you watch in endocrine for INE? Very, very specific. That means please watch prolactin and growth hormone with the tumor management, congenital and acquired hypopituitarism, the causes, diabetes management, everything including drugs, hyperpara and hypopara, and what is primary, secondary hypopara, primary, secondary hyperpara, and then of course pseudo hypopara and that comparison. So all that you need to study. Rest of the things you can just forget because they don't ask anything about anything else. Okay, so that set piece, if you are ready, means we'll just go to the questions. The first question is a pediatric question per se, but we've discussed it under congenital hypopit. Which of the following is the most characteristic feature of Kallmann syndrome? So Kallmann syndrome comes under this heading called hypopituitarism. Hypopituitarism comes under, is divided into congenital hypopituitarism and acquired hypopituitarism. Under congenital hypopituitarism, I told you to specifically remember about 3 syndromes. Most common cause for congenital hypopituitarism was pituitary dysplasia, and pituitary dysplasia was due to this PROP1 mutation. Syndromes associated are Kallmann syndrome, then this Lawrence-Moon-Beadle-Barrett syndrome, then this Prader-Willi syndrome, and Angelman syndrome. So these are the syndromes that I told you to specifically look for. Another syndrome was septo-optic dysplasia. So septo-optic dysplasia, Kallmann, Lawrence-Moon-Beadle-Barrett, Prader-Willi syndrome, Angelman syndrome. Kallmann syndrome, I told you specifically, was degeneration of GnRH plus your olfactory bulb. We have specifically studied it like this. So you get hypogonadism. What hypogonadism? Hypogonadotropic hypogonadism. Along with hypogonadotropic hypogonadism, what do you get? You get anosmia. So hypogonadotropic hypogonadism with anosmia is what we get in Kallmann syndrome. We specified that so many times, and that is why it's a very easy pick. Okay, now if you see this, we will actually get a know-how. This is our slide that we discussed. GnRH and olfactory bulb, Kal gene on the X chromosome, progressing through puberty. We also have some other striking findings. One is color blindness, then we have cleft palate, then we have cerebellar ataxia and optic atrophy. So color blindness, cleft palate, cerebellar ataxia and optic atrophy form the other findings. Okay, so absent breast development, underdeveloped feminine figure, scanty pubic hair. Here also same way, scanty pubic hair, lack of muscle mass, no beard development. So it's hypogonadism that we are actually talking of. Congenital hypopituitarism, these syndromes, all these syndromes we've discussed in detail. PROP, TPIT, HESX1 and LHX3 are the others, of which the transcription factor defect PROP is what is most important. Okay, so this is a very detailed discussion that we have done, and I told you always keep in mind midline craniofacial abnormalities. They go hand in hand with congenital hypopituitarism because of the simple reason that we are having this development from the rat case pouch and the cells migrate across the midline to reach their present position in the anterior pituitary. So every time we are having congenital hypopit, you always keep this in mind. Where do you get hexadactyly, brachydactyly, renal, horseshoe kidney, retinitis pigmentosa, mental retardation, and all these things are part of Lawrence-Boone-Beadle-Barrett syndrome. Okay, so Lawrence-Boone-Beadle-Barrett and Kalman syndrome, how to differentiate, you should be knowing very clearly. And this hypogonadism with pituitary is actually associated with what we call eunuchoid features. And what is the meaning of eunuchoid features? You have lack of adult male hair distribution, infantile genitalia, diminished muscular development, and upper segment lower segment ratio, although is less than 1, arm span is 2 times more than the height. Okay, so this is essentially what is eunuchoid. What are the features of hypogonadotrophic hypogonadism? What are the features of hypopituitarism? Depending upon each, we have actually discussed. And the most important hormone that you have to keep in mind is always your growth hormone. Growth hormone typically characterized by microcephalus, hypoglycemia, prolonged neonatal jaundice, central obesity, round facies with midline deformities with normal IQ. And we have discussed all this, and pituitary dysplasia in this child. Typically, you can see hypogonadotrophic hypogonadism with this centripetal obesity and what we call as this cherubic facies. Okay, typical growth hormone deficiency. And post-pubertal onset, you can see if you are having hypogonadism, what will be normal? Skeletal proportions are going to be normal, scrotum normal, prostate normal, and penile length normal. So penile length, scrotum rugosity, prostate size, and skeletal proportions are going to be normal in a post-pubertal onset hypogonadism. So how to differentiate that, all that we have discussed in detail. Please go back and see that module. INI specific module it is, because even if you don't know this much detailing with respect to NEET, nothing will happen. In INI, it's a goal scoring territory, congenital and acquired hypopit. So you have to be watching it in detail. For NEET, even if you have a baseline understanding of that, it's more than enough. Okay, the next question was on mechanisms of hormone action. Mechanisms of hormone action would have been discussed by Krishna Kumar, but I have told you this very specifically. G protein coupled receptors acting via cyclic AMP is called GS or GI, depending upon whether it's increasing or decreasing cyclic AMP. Acting via IP3DAG is called GQ. Acting via cyclic GMP is called GT, or T standing for transducin. And the question was phospholipase C acting via. Phospholipase C is the one that gets converted to inositol phosphate and diacylglycerol. We know that, and that is what we actually call as GQ. So same question, same thing. Vasodilators, nitric oxide, ANF act via GT. They act via cyclic GMP. Hormones acting via cyclic AMP, hormones acting via IP3DAG. That's something which we've discussed n number of times. As far as hypothalamic hormones are concerned, corticotrophin releasing hormone acts via cyclic AMP, TRH, GnRH act via IP3DAG. Pituitary hormones, everything acting via cyclic AMP, To be very specific, this is what I've wrongly written. V1 and V3. In vasopressin act via IP3DAG, oxytocin acting via IP3DAG. So all the anterior pituitary hormones act via cyclic AMP. Growth hormone prolactin have a different action, that is Janus kinase. Posterior pituitary hormones, vasopressin repeatedly asked for the exam. V1 and V3 act via IP3DAG. V2 acting via cyclic AMP. All the vasoconstrictors act via IP3DAG, primarily because it acts by increasing calcium. Pancreatic hormones, glucagon, somatostatin act via cyclic AMP, of which somatostatin is very important because it decreases cyclic AMP. Very important point. Secretin acting via cyclic AMP, cholecystokinin, gastrin, again causing contractions, so they act via IP3DAG. Alpha 2 and beta act via cyclic AMP. All the others act via IP3DAG. So alpha 2 again very important because it decreases cyclic AMP. Alpha 2 somatostatin, very important, decreasing cyclic AMP. Parathormone, calcitonin via cyclic AMP. This is something which I have taught you at the beginning. The first module itself in medicine is endocrine mechanism of hormone action. We will definitely get a question on that, either from my side or from Krishna Kumar's side. Please study this. Okay, next question is on your acquired hypopit. Before we go to the acquired hypopit, let us just see this question. Which of the following anti-diabetic drugs is associated with increased risk for fracture? Pharmacology question, but I think even from medicine side, you can very easily answer this. That is your PPAR gamma agonist. What is your PPAR gamma agonist? pioglitazone, rosiglitazone, thiogloitazone, all these things which we have discussed in so much detail. I told you once they came to the market, they were like heralded as big superstars because they could combat insulin resistance, and for the first time after metformin we were having a drug that could fight against resistance. But then we understood that they had some issues. One major issue was salt and water retention. Second major issue was they were having increased propensity for fracture. Then we understood that they could cause increased risk for CA bladder, and they were the market in 2010, again reintroduced to the market in 2012-13, but now not a favored drug. So that whole history I have mentioned to you. So increased risk for fracture is rosiglitazone. And now the wonder drugs, that is your SGLT2 inhibitors, and lots of advantages with respect to SGLT2 inhibitors: decreasing oxygen consumption, decreasing cardiovascular mortality. It is a part of heart failure management now. Weight loss, reduced epicardial fat and decreased leptin production, direct inhibition of sodium hydrogen exchanger, reducing systolic BP, natriuresis and diuresis with no tachycardia, reducing hyperfiltration, so does even preventing the fall in GFR. So it's like a wonder drug. All these advantages are for SGLT2 inhibitors. We've done a specific module on SGLT2 inhibitors in our updated sessions in edition 5. So we had updates in edition 5. In that update, one update is on SGLT2 inhibitor. So there we have discussed all this in detail, and you can see that this is a basic pharmacology question, just testing out whether you know the drug. Okay, then this is pioglitazone, what we have discussed. Now, a diabetic patient's fasting blood glucose level is found to be 160. What is the best piece of advice that you can actually give him? Now, these are two slides that I have told you with regards to non-pharmacological management, and this is what CMC Vellore has to say. This is a slide from CMC Vellore. What CMC Vellore people have told us is that let us try to minimize fat. They have not told exactly how to minimize fat, but they have said that 3 teaspoons to 5 teaspoons per day of visible fat is what we need to be using, and 500 grams per month. So try to be using visible fat rather than invisible fat, like refined oil or a desi ghee or something like that. And that shouldn't be more than 3 teaspoons to 5 teaspoons. Protein intake is 1 gram per kilogram, and 50% of protein intake should actually come from the classical sources, and good quality proteins, again they have mentioned. All this I told you. Carbohydrates, we use more of complex carbohydrates which are gradually absorbed rather than the simple carbohydrates. So roti, oats, bread, fruits, vegetables, they are more complex carbohydrates, and 50% of the total calorie from complex carbohydrates. This is what I told you about the table in total. Just get an idea, and I told you this is more for a dietitian to discuss, and if you want more data with respect to this, just get to me personally, we'll discuss on that. Harrison is also given us a table. This also we discussed, trying to tell that there is no role for any trans fat. Try to cut down on trans fat as much as possible. Try to have a diet which is hypocaloric diet. Sucrose containing foods are actually speaking better, and fructose is preferred over sucrose. Fructose is most preferred. Dietary fibers as like general population, and routine supplementation is not advised. This is what we have studied. Now let us see the question. Question is very simple. At least 80 mg dietary fiber. Dietary fiber per se, as you can see over here, as we've discussed also, just like normal population. Salt restriction, dietary fiber, etc., just like normal population, they don't give us any benefit. And cholesterol correct number we have not actually seen anywhere. Less than 30% of the calories should be coming from fatties. Almost 50% should actually be coming from complex carbohydrate. Remaining 30-40% should be coming from protein. So naturally speaking, this is a right statement. So although this is like a dietitian question, not a proper medicine question, you can understand that dietary fiber is like normal in diabetic patients. Salt intake is for hypertension and not for diabetes. Cholesterol less than 100 milligram, nowhere it is mentioned that way, and this is a more logically correct answer. So the same tables that we have discussed is the same thing that they keep on asking in one way or the other. Exact data is not there in the table, but we have actually got a base idea. With that base idea, we can come to the answer. Okay. This is the next question. This is also a question on hypopit. A 30-year-old female presenting with a postpartum period with palpitation, dizziness, hypotension. Postpartum hypotension, apoplexy, Sheehan, you know that. Refractory to resuscitation, BP only 70-30. What will you give? You will give steroid. Even if you don't know anything in this question, you can mark it as steroid. What they mean is that Sheehan is postpartum pituitary necrosis. On top of that necrosis, you can get apoplexy, or on a tumor, you can get apoplexy, or even with sickle cell, you can get apoplexy. Rarely with diabetes, hypertension, spontaneously, you can get apoplexy. When you get apoplexy, you will come with an emergency. It is a first endocrine emergency. In the whole chapter called pituitary, there is only one endocrine emergency, and that is pituitary apoplexy. When a patient comes with pituitary apoplexy, they'll be having neurological symptoms because of the bleed. They can have all kinds of that. And plus they'll be having hypotension and tachycardia, and the first thing that you do is to give steroid, IV steroid and IV hydrocodone. Okay, we have seen that. So Sheehan or spontaneously in adenoma, hypertension, diabetes, endocrine emergency over 1 to 2 days, coming with hypoglycemia, hypotension, CNS bleed and severe headache, and steroids bar decompression. This is what we have studied. These are all the causes that we have studied, and this is fully bleeding into the tumor. You can see patient developing ptosis, sudden onset ptosis, and T1 weighted image actually non-contrast showing bleed. Okay, so that is about your pituitary. So 5 questions in endocrine that came for INI. You just observe these 5 questions. What have you understood? Mechanism of hormone action. Every time they will ask a question. Prolactin and growth hormone. They may ask, may not ask. Congenital and acquired hypopit. Definitely they will ask you questions. Diabetic drugs. They will definitely ask you a question. Diabetic management. They will definitely ask you questions. Even if you don't study the other things, you're perfect. We have had no new questions, no new scenarios emerging. Okay, so it's like they follow the same route. That's what is equal to a penalty corner conversion in hockey. Okay, now we go to the second chapter. That is equal to hematology. And hematology always has extreme high yield with respect to the exam. Drug-based questions in lymphoma, Hodgkin's disease in total, multiple myeloma in total, anemia, this whole thing called microcytic hypochromic, and how to differentiate. That's all what they ask you. Even if you don't know anything else, it's perfectly okay. Let us see. Anemia of chronic disease, what is right, wrong, etc. We have seen this so many times. In iron deficiency anemia, your iron stores are low, so ferritin is generally low, but because ferritin is an acute phase reactant, it can be normal or increased. When iron stores are low, body tries to synthesize more transferrin, so TIBC is high because it is indirectly what is equal to transferrin. Serum iron is the amount of iron in circulation bound to transferrin, that is low. So when your serum iron by TIBC, what you actually put as your percentage saturation of transferrin, that will be low. This is equal to iron deficiency anemia. In anemia of chronic disease, it is a problem with utilization because of hepcidin high. So ferritin is normal to increased. Yes, but iron cannot come into circulation, so serum iron will be actually speaking very, very low. Your TIBC is your iron stores, so it's like normal stores, so we don't want to synthesize, so TIBC is actually low. But serum iron being very low and TIBC is actually speaking low, the serum iron is very, very low, so your percentage saturation of transferrin is also on the lower side. So serum hepcidin high, yes, hepcidin is what is inhibiting ferroportin. Iron stores are normal to high, iron stores are normal to high. Serum ferritin is low, never. Serum ferritin is normal to high. And chronic infection inflammation. It's more chronic inflammation rather than infection, but anyway, leave it. But serum ferritin has to be normal to high. Serum ferritin low is equal to only one disease in the world, that is iron deficiency anemia. Okay, so this microcytic hypochromic anemia approach, I think we've done this so many number of times. Just look into the question, C for ferritin. If ferritin is low, mark the answer there itself, iron deficiency anemia. If ferritin is normal to high, look into serum iron. If serum iron is low, mark the answer as anemia of chronic disease. If serum iron is on the higher side, mark the answer as sideroblastic anemia. This much is enough to actually answer all the questions. Okay. 60-year-old woman presents with complaints of fatigue and dyspnea for 2 weeks. Pallor, hemoglobin found to be 6. What will be the finding mostly seen on the peripheral smear? So, most common cause for anemia is what they have asked. Most common cause for anemia is, of course, iron deficiency. And because the patient is having symptomatic iron deficiency, she will be having microcytic hypochromic. Although some cells may be normocytes, some cells may be microcytes, but you will be expecting microcytic hypochromic. If you know that, you can mark the answer. But definitely there will be high degree of anisopoikilocytosis. So if high degree of anisopoikilocytosis is mentioned, then that also you have to consider. But here they have not asked like that. Yes, and here you can see the differences in what we have discussed. Boy presenting with recurrent episodes of melena, eczema, peteke, platelet count low. What more you want? Recurrent eczema, recurrent episodes of eczema, plus recurrent sinopulmonary infection, plus recurrent thrombocytopenia. Recurrent eczema, recurrent sinopulmonary infection, recurrent thrombocytopenia with small sized platelet. With small sized platelet is equal to Wiskott-Aldrich syndrome. And Wiskott-Aldrich we've discussed in detail so many places, along with ulcerative colitis I have made a mention, along with qualitative disorders of platelet function I made a mention. This is due to what mutation? VASP gene mutation. Okay, so these questions are also like, I think, very straightforward. No? There is nothing much that you need to think about this in detail before you answer. You can more or less get to the answer without wasting time. Okay, as far as rheumatology is concerned, be thorough with the antibodies, because every time we have questions on antibody matching. This time they didn't, but every time they ask you that. And management of RA, SLE and ANCA vasculitis. And that will not so much in detail. Generally, how you manage and what you do. Like in a very superficial level, if you know that, that's more than enough. Which of the following is not a first-line drug for the management of a patient with rheumatoid arthritis? This is the only question that came from rheumatology in this INI. And you know that it is treat to target. Yes, whatever hook or crook you treat to target. We have DMARDs on one side. So we start off with DMARDs always. We start with methotrexate. That is actually speaking enough. Some people have the habit of starting with methotrexate, with HCQ, and with sulfasalazine. That is another way of starting, but we start with DMARDs, methotrexate alone. Finding that it is not responding, we're treating to target and we have responsive score. Then we start about thinking about biologics or small molecules. Now, because small molecules are oral and they are more easy to use, we may use JAK inhibitors at this point, like a tofacitinib or something. Then biologics, of course, our first choice is anti-TNF-alpha. Anti-TNF-alpha is our biologic first choice, and that can be infliximab, adalimumab, etanercept, anything like that. So sulfasalazine, HCQ, methotrexate, it is like first choice. As I have discussed, they are like the combination therapy used in the beginning for all patients. Some of the patients we start with methotrexate alone. We at our center and my practice, we start with methotrexate alone. We don't want to overburden the patient. If not working with methotrexate, we go straight to JAK inhibitors, or we give them the option of anti-TNF-alpha. Azathioprine has nothing to do in the first line management. It's a very simple question. Azathioprine has nothing to do in the first line management. Okay, that's it. So nothing much to study in rheumatology. Only if you focus on this, that is more than enough. But a person who has got grounded knowledge only can come to this fine tuning. That is there. That means somebody like Harmanpreet Singh cannot learn only scoring of a penalty count, although he's a specialist. But his basic knowledge is what that matters. That means without studying medicine, you cannot become a nephrologist. Straight away, you cannot go and become a cardiologist. So straight away, you cannot become a penalty count specialist. You need to have rounded knowledge. Then only it's possible to convert. Glomerular disease causes often asked, everything about potassium asked, and GFR. These are the three things. If you know this, you are mostly safe with respect to INI nephrology. Let us see. Which of the following is not used in the emergency management of hyperkalemia? This again I have actually told in one of the modules, or not in the modules, in the class actually speaking, that if your college is not taught you how to manage hyperkalemia, then that's a serious offense. It's a serious offense because we see a lot of patients with CKD who get dialyzed twice per week, no, because of financial constraints. So Monday, Thursday. So after Thursday, before the next Monday, we are having so many days gaps. So they can present with hyperkalemia. So you should be aware of how to administer calcium gluconate. That's your first line. So calcium gluconate, insulin dextrose infusion, salbutamol nebulization. Everybody knows. Maxalf has nothing to do with this. So very straightforward question, but always keep in mind 10 ml, 10% calcium gluconate slowly over 2 to 3 minutes. That is first line. Then IV insulin plus glucose. That means 10 units of insulin you give, 50 ml of dextrose you give. Okay, 10 units of insulin you give, 50 ml of dextrose you give, or insulin dextrose infusion also you can give. Nebulized salbutamol 20 milligrams, okay, in 4 ml. 20 milligrams in 4 ml. It's very, very high dose that we give. So calcium gluconate first line, short-acting insulin with your dextrose. Don't just give dextrose, that is useless. And your albuterol or salbutamol 20 mg, that's what we give. Then potassium binders we can try giving. Patchomer is coming to the market. All that is there, but these are our three major frontline things. Maxalf and all, no value. This is very basic question. 4-year-old male child with a body weight of 15 kg, height of 100 centimeters. Now, this is basically equal to your Schwartz equation. I think I have also taught you Schwartz equation. Singaram has also taught you Schwartz equation. Schwartz equation is equal to K into L by creatinine. Okay, K into L by creatinine. As far as a 4-year-old child is concerned, this is the correct value for K. 0.33 in preterm, 0.45 in full term, 0.55 in 1 to 12-year-old. So, 0.55 in 1 to 12-year-old. So, this 0.55 in 1 to 12-year-old, so we can actually take it as 0.55 into length of the child, which is equal to 100 centimeters, divided by creatinine value, which is 1. So it comes to 55 ml per minute. Okay, so 55 ml per minute. Now, there is a confusion over here because some books have randomly mentioned 0.45. Now, that is actually speaking wrong, and they have given little confusing options also. This is the exact value. I have also not taught the exact value, and I feel bad about it now. 0.33 in preterm less than 1 year, 0.45 in full term less than 1 year, 0.55 in 1 to 12-year-old and adolescent girls, 0.7 in adolescent boys. I never thought they'll ask you a question on this. So what happened is I randomly told in class that the value is 0.4. You can take it as say 0.4. If you take it as 0.4 and calculate this question, you get 40 as the answer. The answer is not 40, it is 55. Because it is very clearly given that this is a child who is 4 years. And you can see 1 to 12-year-old child, the value is 0.55. So very sorry for this, because nephrology questions extra when you get wrong, I feel bad about it, because this is a question which I have told the equation, Schwartz equation, K into L by creatinine. I have shown on screen K into L by creatinine, and I have told randomly it is 0.4. That's correct, actually speaking. Randomly it's 0.4. I never thought GFR based equation they'll ask you every time. That's all Cockcroft and Colt based. So everybody knows 140 minus age into body weight by 72 into creatinine into 0.85 for females. Everybody knows the equation. Schwartz also we know, but I never thought they'll ask you to calculate on Schwartz. So this is actually something which I missed and I feel bad about it. Okay, liver and MG, of course, this hepatitis B and IBD, only two things, nothing else. Once again, chronic HBV, HBsAg, anti-HBC IgG, and HBV DNA. There is nothing to discuss. We can see this detailed discussion again in INI NEET paper that I have done, and every time I have done this, I told you liver is the closest topic to heart as far as me, the individual, is concerned. So I don't want you to miss out anything. Anybody having anti-HBC IgM positivity is equal to acute hepatitis B. Somebody having HBsAg positivity with anti-HBC IgG positivity is equal to chronic hepatitis B. In that, based on HBV DNA, we can look into the viral load. If you are just anti-HBC IgG positive, it is a remote infection. If you are just anti-HBS positive, that means you are vaccinated. If you are anti-HBS plus anti-HBC IgG, that means you have recovered from acute hepatitis B. Okay, this again in detail we have done. Mark the correct statement regarding IBD. And IBD is again something which we have done in toto, in detail. Crohn's is curable through surgical resection? Nothing. Inflammatory bowel disease has strong genetic predisposition. I have actually shown a slide here, and I think I mentioned that also. In monozygotic twins, 6 to 18% concordance, 38 to 58% concordance in monozygotic twins with respect to with respect to Crohn's disease, and 6 to 18% for ulcerative colitis. So actually speaking, you are having genetic predisposition. It is there. Mucosal layers are involved in Crohn's, whereas transmural involvement is seen in ulcerative. It's the other way around, which all of you know. Skip lesions are present in Crohn's is correct. Inflammatory bowel disease has a genetic predisposition is also correct. Actually, this question has two correct answers, but strong is a very relative word. How do you know whether it is strong or weak? I really don't know, because 6 to 18% I feel is strong. You may feel it is not strong. Dizygotic twins, you can see only 2%, here 4%. So dizygotic not that much, monozygotic it is there. So it's a relative term, but skip lesions are present in Crohn's is a 100% right statement. So because of which we have to mark that, although C is also not wrong. So please study this, very, very important. Smoking is causative in Crohn's disease. Smoking is actually speaking protective in ulcerative colitis. OCP has got association with Crohn's disease. This is very important. Appendicectomy is actually speaking protective in ulcerative colitis. And all these syndromes associated, and that is where I have mentioned, see this Viscout-Aldrich syndrome, colitis, immunodeficiency, platelet, thrombocytopenia. We mentioned about glycogen storage disease, Hermansky-Pudlak, Turner's, this IPEX syndrome, and early onset IBD. IPEX syndrome is also very important because it has been asked. Loss of FOXP3, it was asked, associated with endocrinopathy, diabetes, dermatitis. So the first two opening slides as far as disease is concerned is this. And genetic, you can see here with respect to Crohn's, we have talked about this NOT2 gene mutation, or what we call CART15, NOT2 CART15. But how much strong genetic it is, this is the actual data. So it's slightly confusing question. I feel it is enough if you mark it as skip lesions, although C is also partly right. Cardiology again is only about ECG. And even NEET also is like that. If you know basic emergency management, you are safe. This is a simple case of a narrow QRS tachycardia or normal QRS complex tachy. The moment you are having narrow QRS tachycardia, you look for whether the rhythm is regular or irregular rhythm. I have given you the basic outline in my NEET discussion. Regular rhythm means you look for, see, regular, very, very regular, and the rate is say about 1500 divided by 7 almost. So it's almost like 200 per minute is the rate. So regular, 200 per minute is the rate, which means that narrow QRS complex, regular RR interval, 200 per minute, no P waves, absolutely no P waves to be seen. So 100% what comes to your mind first is AV and RT. 100% what comes to your mind first is AV and RT. One part of the discussion I have done there. So quickly actually looking into that, we are having arrhythmias due to re-entry. We are having arrhythmias due to triggered activity. We are having arrhythmias due to automaticity. These are the three mechanisms, of which re-entry is the most common mechanism, and that is most responsive to any form of electrical cardioversion. Triggered activity has a plus or minus response, and automaticity has a poor response to DC cardioversion. This is the basic idea. Re-entry can be due to macro re-entry circuits. It can be due to micro re-entry circuits. When you think of macro re-entry circuits, AV RT comes to your mind. Atrial flutter also comes to your mind. These are two Very important macro reentry circuits. VT, especially what we call SCAR VT, monomorphic SCAR VT, has macro reentry circuits. Micro reentry circuits, AV, NRT, and AFib are the two classical examples for micro reentry circuits. Triggered activity can be due to EADs or DADs. EAD is equal to early after depolarization, DAD is equal to delayed after depolarization. Early after depolarization, the classical example that we study is a polymorphic VT plus prolonged QT, what we call as a torsade pointers, which has a different set of causes. Unlike a monomorphic VT, which is SCAR based, polymorphic VT is hypokalemia, drug and all based. DAD is due to increased sympathetic activity, and that is equal to your VT again, different VTs, LVOT VT, RVOT VT, and all those things. That is sympathetic activity mediated. Automaticity is actually either enhanced automaticity or abnormal automaticity. Enhanced automaticity is from the sinus, what we call as sinus tachycardia. Abnormal automaticity can be from the atrium, what we call as atrial tachycardia, or from the AV node, what we call as junctional tachycardia. So atrial tachycardia, junctional tachycardia, even some forms of VT, they are all having abnormal automaticity. That's why one arrhythmia can have more than one mechanism. So these many arrhythmias are there for our exam. This is our anatomical classification. From this anatomical classification, when we try to look into another form, that is clinically how we classify, means when we get a tachy, we try to see whether it is narrow QRS or a wide QRS. Wide QRS is VT unless proven otherwise. We just keep it as VT, and we discuss management of VT in the NEET recall session. Narrow QRS, we look for irregular RR interval. Irregular RR interval is AFib, and with irregular RR interval, when you are having 3 or more different morphology P waves, then you think of MAT. That's a different disease altogether. MAT rate will not be even close to AFib. AFib will be having very high rates, MAT will be having slightly less. And whenever you are having MAT, think of lungs. COPD is the most common cause. Okay, when you are having narrow QRS complex with regular RR interval, again, what all comes to your mind? AV NRT comes to your mind, AV RT comes to your mind, atrial tachycardia comes to your mind. Okay, of which if you are having no P waves, absolutely no P waves, then AV NRT is only possible. AV RT, because it is a re-entry around big circuits, will have a P wave which is subscribed outside the QRS complex. And atrial tachycardia will have a P wave before the QRS complex. So, no P wave, you can just like that mark the answer as AVNRT. AVNRT or AVRT or atrial tachycardia in a hemodynamically unstable patient requires DC cardioversion. Here they have not mentioned hemodynamically unstable patient, rather vitals are stable. Whatever it is, when vitals are stable for all the three, first we give adenosine. Okay, adenosine is having a half-life of only 6 seconds. Only 6 seconds. So because of which you give 6 mg IV adenosine, then 12 mg IV, then 12 mg. Maximum 30 you can give, but with 6 mg itself around 70% will revert. With 12 mg 95% will revert. The problem is we don't give it correctly. See, arm to heart circulation time is 7.5 seconds. Arm to arm circulation time is 15 seconds. So when arm to heart circulation time is 7.5 seconds, if you are giving through the peripheral line here, then by the time it reaches the heart, it would have already, its half-life would have been done. So you have to either give it through a central line or through a peripheral line which is above your brachial, and then lift the arm and actually put the patient in prone position. That's the exact technique, and follow it with what is called as a saline chase, and we have discussed that, how to give it, etc. in our module. So adenosine is the main thing. Adenosine danger is one, bronchospasm. It can produce bronchospasm. So in a person who is having COPD, it is not to be used. And as cardiologists always say, it will give you a feeling of impending doom. So you have to mention that to the patient. And very, very importantly, if the diagnosis is not AVNRT, and if it is suppose AVRT, and AVRT is associated with WPW syndrome, and WPW syndrome has a tract from the atria to the ventricle, and suppose that is working, it's a rare possibility, 1%. A lot of impulses can like that come from the atria to the ventricle through this tract, because the normal AV node you are blocking. So that can come and can produce VT, VF, and the patient can die. So that is a rare chance only. Otherwise, adenosine is a super drug. The main point to be kept in mind is you should know how to give adenosine. That is not required for the entrance exam, but in practice you should be knowing how to give adenosine. Really, giving adenosine is of no value. You have to give adenosine keeping in mind that its half-life is actually speaking so less. Okay, so because its half-life is actually speaking so less, if you don't give it in the exactly right way, then it is of no value. Okay, so that's about this question. Again, with minimal knowledge, you can answer that. Infections are very important. So somehow for INI, you have to study in detail. I have discussed, Shivika madam has also discussed, watch micro videos again and again, have solid understanding about infection and HIV. Very, very important. Some question or the other you will get. Which of the following is true about anti-CMV IgG? It's like anti-dengue IgG. We said before transplant we check for this. Everybody will be positive. So anti-CMV IgG indicates acute infection, never it is anti-CMV IgM. Differentiating past and primary infection, nothing like that. It just indicates that you are having infection. Denotes chronic CMV infection with immunity to other serotypes, nothing like that. You can get a new serotype infection. Denotes latent CMV infection. Yes, you are having a latent CMV infection. That is the only thing that it can actually tell you. So you are having a latent CMV infection. You have been exposed to the organism as a child. Everybody has been exposed to the organism as a child. So that's all that it can tell you. When you're having IgM only, you can talk about it. Even that has very little value. CMV DNA PCR is what we are looking for. HIV patient and prophylaxis, I have actually discussed this in detail. What level of this thing you get what infection. And we have studied that at each level you are getting different infections. This question is basic common sense question. See, PCP you leave, coccidioids you leave, MAC and all you leave. Cryptococcal meningitis, who can give prophylaxis? Can we give prophylaxis for cryptococcal meningitis? There is nothing called prophylaxis in cryptococcal meningitis. If you get cryptococcal meningitis, you can treat cryptococcal meningitis. What else can you do? We give prophylaxis for a lot of things that I've told you very clearly. PCP we give prophylaxis. Toxoplasma gondii we give prophylaxis. All that cotrimoxazole we give. Mycobacterium as well as MAC we give prophylaxis. Streptococcus pneumoniae we give prophylaxis. Influenza we give prophylaxis. Rest of the things there is no role for any prophylaxis. Okay, and even fungal infections like coccidioidomycosis, histoplasma capsulatum, there we give prophylaxis. Actually speaking, these are the conditions where you give prophylaxis. So you can see once again, as we have discussed, pneumocystis carinii pneumonia, Toxoplasma gondii, we give prophylaxis. Mycobacterium, MAC, Streptococcus pneumoniae, influenza, we give prophylaxis. Histoplasma, coccidia, syphilis, varicella, HIV, we give prophylaxis. Which means these many areas we give prophylaxis, correct? After giving prophylaxis in these many areas, this is what they have asked. Where is the prophylaxis for Cryptococcus? There is no prophylaxis. That way you can answer this question. Leave. Otherwise, prophylaxis for PCP is indicated when the count is actually less than 200. That's very clear because you can see over here, less than 200, we have always talked about PCP pneumonia, esophageal candidiasis, mucocutaneous herpes. Very clear. 500 is zoster, here it is mucocutaneous herpes. Less than 100 TCC. Toxoplasma, Cryptococcus, coccidioidomycosis, even cryptosporidiosis. All these things actually are between 50 to 100. Less than 50, you can have two major diseases, CMV retinitis and something called your Mycobacterium avium intracellularly. And 50 to 100, we can also get your progressive multifocal leukoencephalopathy, PMLE. Okay, so PMLE between 50 to 100, less than 100 you can also get Toxoplasma, Cryptococcus, coccidioidomycosis and cryptosporidiosis. Less than 50 we get MAC and CMV retinitis, that is all asked. And where do we give prophylaxis? I have told you, we give prophylaxis for Toxoplasma and we give prophylaxis for PCP, that's mandatory. When it comes to less than 200 we give for all patients. And as usual, Streptococcus pneumoniae, influenza, HIV and all that. Coccidioidomycosis, blastomycosis, we give prophylaxis. And we also give prophylaxis for TB and Mycobacterium avium intracellularly. So all that is there. And I told you, these are the three AIDS-defining malignancies: Kaposi sarcoma, NHL, invasive CA cervix. And this again has been asked so many times. Leave it. Now let us come back. Prophylaxis for MAC is indicated when CD4 is less than 50. So this also is a correct option. Where students had confusion was these two options. And this is definitely tough because stopping prophylaxis if the count is more than 250, many people thought like we should never stop prophylaxis. It's not like that. Once your CD4 count is more than 250 or 300, then you can actually stop this. But that is a little tough. That's why this question is actually speaking very tough. Many people mark the answer for this question as this. But the basic common sense is we can never prevent Cryptococcus meningitis. We cannot give prophylaxis for Cryptococcal meningitis. We can only treat Cryptococcal meningitis. That was what they wanted you to know, but it was a little tough. Okay, so there's a limit to which we can prepare infections. As I keep on telling you, we can study and hope that what comes we know. Fever and chills, RK39. RK39 is Kala-Azar, you know that, and amphotericin B, liposomal amphotericin B. AIDS-defining malignancies, all of you know, invasive CA cervix, non-Hodgkin's lymphoma, Kaposi sarcoma, so melanoma is the answer. All that is very, very easy. Then, Plasmodium falciparum, features of severity, and we have had a table discussion on this. All this is severe: acidosis, anemia, renal failure, pulmonary edema, hypoglycemia, hypotension, DIC, convulsions, and I have discussed that. And you can actually see it over here. Glucose less than 40, you know. Renal failure, you know. Unarousable coma, you know. And it is not alkalosis, it is acidosis. So please go back and revisit this table. Everything in this table is actually speaking very easy. I have also told you this, what are the manifestations of severe plasmodium falciparum, and there is nothing to actually discuss in this. We know that there can be acidosis, we know there can be anemia, there can be renal failure, that is black water fever and hemolysis, pigment nephropathy, pulmonary edema, which is non-cardiogenic pulmonary edema, hypoglycemia because of the organism consuming sugars, hypotension, bleeding, DIC, convulsions. Common sense, even if you don't know this, you can answer. Most of the people got this question right. I don't know anything that is something which you can confuse this with. Some people thought there is no renal failure. And that's as part of hemolysis, you can get renal failure. Okay. Neurology is so simple. Just to tell me where is the site of lesion. That's all what they will ask you. What will localize the lesion to the spinal cord, or what will not localize the lesion to the spinal cord? Crossed hemiplegia, contralateral hemiplegia means what are you seeing? Hemiplegia itself means it is not in the spinal cord, and crossed hemiplegia is classically seen with the brainstem. Correct? You see with the brainstem. So which of the following does not help to localize means brainstem. Naturally, because brainstem will actually tell you that ipsilateral element cranial palsy, contralateral hemiplegia. So simple. Okay, element at the level of lesion, UMN below the lesion is obviously equal to spinal cord, fasciculation, anterior console spinal cord, bladder bowel spinal cord, everything you know. Tongue fasciculation. Fasciculations are part and parcel of anterior console. Fasciculation, wasting, atrophy. Keep on telling. Asymmetrical involvement, fasciculation, wasting, atrophy. Asymmetrical involvement, fasciculation, wasting, atrophy is always equal to anterior console, anterior console, anterior console. Okay, so please don't ever have a confusion with respect to this. We have discussed a case like that. That means when somebody comes with a bilateral weakness question, okay, acute onset bilateral weakness question. In acute onset bilateral weakness question, you look for whether it is a flaccid weakness. Okay, flaccid weakness. Once it is a flaccid weakness, you know it is LMN, or you know that it is UMN in the stage of shock. UMN in the stage of shock bilaterally means spinal cord. So there you can think of what answer? You can think of transverse myelitis. That is one possibility. LMN means you can think of sensory motor. Sensory motor means nerve is there, root is there, plexus is there. Then you have pure motor. Pure motor means anterior console is there, NMJ is there, muscle is there. These many things you know. Because it is only motor, you strike off this. Anterior console will have more chronic involvement, asymmetry, fasciculation, atrophy, all those things. So you strike it off. NMJ will have fatigability and extraocular muscle weakness, ptosis, diplopia. Strike it off. So what remains here? Muscle remains here. Then you can have bilateral polyradiculoneuropathy. What is bilateral polyradiculoneuropathy equal to? That is equal to GBS. Okay, so GBS is one possibility, muscle is another possibility, transverse myelitis is another possibility. Transverse myelitis will be having, what will be there? Definite sensory level, and will be having bowel and bladder involvement. So you strike it off. GBS will be having sensory for 2 or 3 days predominating. Before that, after that only motor along with autonomic nervous system. So you strike it off. Pure motor weakness is muscle. And then go behind the cause for muscle. So that is localization, and that same localization questions they keep on asking. Tuck fasciculations are seen where? In spinal muscle atrophy, that is anterior console. Anterior console diseases can be combined element UMN, that is ALS, pure UMN, that is primary lateral sclerosis, pure LMN, that is spinal muscle atrophy. Yet another question on localization, hemisection of the spinal cord, Brown-Sequard syndrome, and all of you know, because when you are having the spinal cord like this and when you are having a hemisection this way, your corticospinal tract has already crossed at the level of the medulla and is coming down. So you'll be having ipsilateral corticospinal tract findings. Your posterior column will go to the medulla, then cross and go to the opposite side, which means if you cut it at this point, you are having the same side. It's from here that it's coming. It's crossing only at the level of the medulla. So ipsilateral will be having posterior column. Your spinothalamic tract, on the other hand, is actually crossed from this side and then it is going up, which means if you cut it means you'll be having contralateral spinothalamic tract. So it is not complete transection, it is a partial transection. Ipsilateral posterior column right, contralateral spinothalamic right, and same side you'll be having loss of proprioception, that is posterior column. So same side motor, same side you'll be having proprioception, opposite side you'll be having spinothalamic. This is you're studying this from first year MBBS onwards. Everybody knows it is hemisection. So complete cord transection, what happens, hemisection, what happens, extramedullary, what happens, intramedullary happens. We have discussed at different levels. So please go back and see. INI, you will get questions on localization. Keep on getting questions on localization. Respiratory system is just studying PFT, ILD, pneumonia. You don't have to study anything else. But whatever you don't study, this is the only stock question, man. This question they are asking again and again. I am myself fed up of discussing this question. It's very simple, actually speaking. The moment you see, don't look into this construction company and all. FE1 by FEC is 0.4, which means when FE1 by FEC is actually less than 0.7, you are having what disease? We are having obstructive disease. Obstructive diseases include COPD, asthma, bronchitis, bronchiectasis, cystic fibrosis. So that is actually speaking understood. Then After bronchodilation, you're looking for reversibility. And reversibility is equal to 12%, more than or equal to 12%. So FEV1 was 0.9 and it's now become 1.9. It's more than 50% increase. So obstructive disease with bronchodilator reversibility is the answer, which is seen in asthma. So as far as PFT question is concerned, don't ever have any kind of a confusion. FEV1 by FVC, which is low, is equal to obstructive. Obstructive has how many causes? 5 causes: COPD, bronchiectasis, bronchiolitis, cystic fibrosis, and bronchial asthma. Then when FEV1 by FVC is normal to increased, okay, FEV1 by FVC is normal to increased, then we can have a pure vascular disease, or we can have something like a restrictive physiology. Normal to increase, just look into the DLCO, okay, DLCO is low and FVC is normal. So FEV1 by FVC is normal to decrease, normal to increase. FVC is also normal, it's likely to be vascular, where the main finding is DLCO low. Whereas FVC is on the lower side, then it is 100% restrictive. When it is FVC low and restrictive, then we have intraparenchymal issues, extraparenchymal issues. Intraparenchymal issues is ILD, where DLCO is low. So ILD will have FVC low, DLCO low, FEV1 by FVC normal to increase. Vascular will have FEV1 by FVC normal to increase, FVC normal and DLCO low. Extraparenchymal can be inspiratory problem or inspiratory plus expiratory problem. Inspiratory problem, inspiratory plus expiratory problem. Inspiratory problem will have RV by TLC ratio increase. This will be having RV by TLC ratio normal. So that again has been discussed so many times. So RV by TLC ratios increase in inspiratory problem. RV by TLC ratios increase. It's normal in inspiratory plus expiratory problem. Inspiratory problem is myasthenia. Okay, so myasthenia is there. So RV by TLC ratios actually speaking increase there, because total lung capacity decreases. Whereas in a chest wall issue like kyphoscoliosis, because the muscle and parenchyma is normal, total lung capacity is not decreased. That's the reason why ratio is maintained there. It is increased here. So even if you don't know anything, just look into FEV1 by FVC. Reduced is obstructive. Reversible means asthma. Irreversible means COPD and the others. Then if it is normal to increase, look into FVC. If FVC is low, that is equal to restrictive. Inside that, if DLCO low, intraparenchymal, otherwise extraparenchymal. In extraparenchymal, pure chest wall issue or neuromuscular issue or chest wall issue. Neuromuscular issue, RV by TLC increase, otherwise chest wall issue is normal. And then look into your vascular, where everything will be normal, only DLC will be low. That is the only question. Okay, so that is about PFT. And I think this question has come again and again, 1,000 times. Please watch the PFT module. Please watch the flow volume loop module. Please watch the DLCO module. I think that can settle all these things. Frostbite, Rohan sir already actually touched upon. So there's nothing that I need to be discussing here. Just asking you how do you manage frostbite. Rubbing and friction is not required. Rewarming is there, but not by exercise. Then tetanus prophylaxis, antibiotics, analgesics, etc. So amputation in severe cases, yes, rewarming is done. Area is dried and clean. Antibiotics and analgesics not used is definitely a wrong option. So this actually has been discussed in surgery and vascular. That's why I'm not touching upon that. Then of course, this question, like alcohol withdrawal in a patient who has high LFT, you have to be using the shortest acting drug, and the shortest acting drug is lorazepam. Again, psychiatry thing. Which of the following is not a cause of central cyanosis? Central cyanosis means methemoglobinemia, you'll be having nitrates. So when you're having nitrates, Fe2 plus will be converted to Fe3 plus, you cannot utilize iron. So you'll be having kind of anemic hypoxia. High altitude will be having hypoxia. So these are all central cyanosis. Pulmonary AV fistula will be having shunting. Hypothermia is just a localized vasoconstriction because of low temperature. So it will be causing what? Peripheral hypoxia. Simple, no? It's like vasoconstrictions, localized vasoconstrictions will be not central cyanosis, peripheral cyanosis. Or in simple terms, cold, obstruction, LV shock, decreased cardiac output all produce peripheral cyanosis. Whereas polycythemia, high altitude, lung disease, methemoglobinemia, shunts, all these things produce central cyanosis. My second year MBBS code, what we call PALMS and cold. P stands for polycythemia, A stands for altitude, L stands for lung disease, M stands for methemoglobinemia, S stands for shunt. All this is associated with central cyanosis. Kundu, you can see this. And peripheral cyanosis is cold, everything relating to cold. Okay, so it's just trying to hit on the same nail every time, okay. Questions are not complicated, questions are actually speaking very simple, but INI requires a different kind of a preparation. That first you should have rounded knowledge with respect to NEET and you should be very clear with this. Then you want to target INI, means you have to figure out that specific points and read those points or watch those modules in detail. Once you do that, then I think you are up and ready for INI. So INI is that exam where your plan for NEET, you try to just kind of alter the plan a bit. There is nobody who can study only for INI. There is nobody who can study only for NEET. We are preparing for all the exams together. Not all the exams, these two exams together. So prima facie, try to get a rounded understanding through NEET and then apply it for INI. So essentially, the videos are going to help you to develop this rounded understanding. I think that's what matters the most in this kind of an exam. So there is still some time for INI. So just try to brush up the most important topics. Once more, watch the videos of those most important topics and see to it that you will never miss a question on those topics. Questions which come outside those topics are going to be the same for everyone. Okay, so that is INI discussion. Please go and again be sure and solid with the topics again and again repeated in INI. That's the only message as far as INI is concerned. And our preparation is primarily for NEET at all times. And I'm hoping that you are in the right frame of mind and going on as is expected. We're getting into the business end, and that's what really matters, and what we study now really sticks. So utilize your time judiciously, and hoping that you are going to be on the other side with a lot of success. That's just the beginning of your journey, but beginning is what that matters, and a job well begun is like half done. So you have to be starting off well. That's very important. And thank you once again, and feel free to contact anytime with respect to any of your queries with respect to the exam, and more importantly, queries with respect to patients. Thank you.